Late life depression is more difficult to treat than depression of early life for a variety of reasons. First, because there is an accumulation of a good number of patients have early life depression that is recurring and comes back and again, and with every episode the response to treatment is lower, is diminished. However, another group of patients are people who develop depression for the first time in their late life. This last group is called late-onset depression, and they're more likely to have cognitive impairment resulting from brain impairment in circuits that have to do with mood regulation and with cognitive function. The patients with cognitive impairment have been particularly difficult to function, especially those that have impairment in executive functions. The antidepressants work much less well than the antidepressants work in depression, late life depression without executive impairment. This is a finding of my colleagues and my group and has been replicated many times. Antidepressants don't work in the elderly as well as they work in the young, especially and in particular in elderly with some degree of cognitive impairment. And specifically executive dysfunction is what interferes with response to antidepressants. So a number of behavioral therapies have been developed. One of them is problem-solving therapy that I mentioned earlier. Another is a therapy that we developed and we're currently testing. It is called Engage, and it is based on a neurobiological theory in which implicates the reward system as the main system impaired in late life depression. So the treatment was, because it is based on reward exposure, the treatment was simplified to the point that it can be used by clinicians in the community. And the theory is that repeated reward exposures through neuroplasticity strengthens the function of the reward system and therefore reduces depression. While this is the main mechanism of treatment, other type of abnormalities in the brain, such as impairment in the cognitive control system or impairment in the arousal system or impairment in the negative valence system, may contribute to the point that a person cannot get to reward exposure. For example, if somebody has negative valence impairment and clinically presents with negativity bias, anything that you propose to him as a rewarding activity or rewarding function would lose its value because they wouldn't be able to see it.